Hello, and welcome to our training on the role of hospitals and emergency departments and petitioning to the CARE Act. Today, we are going to go over a few different areas. And just to note, all of more detailed notes and links to the different materials are in the materials for this training. So if there's information you want to look over or you want to go to additional resources, you're welcome to do so. So the overview of today's session is first, we're going to provide a brief overview of CARE, the process and eligibility and the range of services that would be available to individuals going through the CARE process. And then we'll look at specifically petitioning to CARE from a hospital emergency department and how you might be involved. We're going to look at a specific referral process from LPS facilities process, and then we are going to look at some workflow considerations of when petitioning or referring would make sense within hospital workflows. Our objectives today is that by the end of this session, you'll have an increased ability to know what the petitioning process is and the role of hospital or an emergency department staff in care. Also, understand LPS facility and care referral process, and use different hospital and emergency department workflows to support the petitioning and referral process. Today's session will be presented by my colleagues, Dr. Deborah Rose and Laura Collins. Dr. Rose is a licensed clinical psychologist with a history of developing and designing initiatives for behavioral health services, and Laura Collins is a licensed clinical social worker with 25 years of experience in psychiatry across the behavioral health continuum. So we'll start off. I'll hand it over to my colleagues to start with an overview of CARE. Hi there. We have an important update regarding the CARE Act beginning January 1st, 2026. Changes made by Senate Bill 27 will go into effect. These changes include bipolar 1 disorder with psychotic features will now be included as an eligible diagnosis under the CARE Act, except psychosis related solely to intoxication. This law now defines what it means to be clinically stabilized and ongoing voluntary treatment. Certain court referrals can now serve as a CARE petition. Criminal courts may consider CARE referrals earlier for individuals found incompetent to stand trial in misdemeanor cases. Nurse practitioners and physician's assistants are now authorized to complete affidavits in support of CARE petitions, and there are also some technical amendments to streamline the CARE process. Our training PDFs, including the notes, have been updated to reflect these changes, including the addition of bipolar 1 disorder with psychotic features, and they are available on the CARE Act Resource Center. But during this training video, you may hear older references to schizophrenia and other psychotic disorders, so keep this update in mind that it will now include bipolar 1 disorder with psychotic features starting January 1st, 2026, and other updates made by Senate Bill 27. Thank you for staying informed, and please review the updated resources linked in your training materials. You can find more information about these changes in our SB 27 brief on the CARE Act Resource Center, or email us at info@careact.org.
Thanks, Patricia. Why don't we begin with CARE at a glance? This gives us a high-level overview of the CARE Act. CARE is a new civil court process. It's an upstream early intervention process, and it really focuses on recovery and autonomy for individuals who are involved. CARE has created a roadmap to deliver behavioral health and substance use services to some people who really are experiencing some difficult times as a result of their behavioral health condition or symptoms. These are people who are often street homeless or unhoused, and folks who may be involved as the legal system as a result of the impact of the illness on their functioning. So really the design of CARE is to get people connected to services in their community. There are multiple paths in. There are different ways that multiple petitioners can begin the process, and that starts when they believe that somebody is eligible for CARE. The path continues with services provided and offered throughout, and there are multiple paths out, so that it's really designed that services are continued when the CARE experience ends. So again, the upshot is that the goal of this is really to provide robust services that wrap around the individual to provide intensive support. Let's go to the next slide, please. Specifically now, We've talked about that this is a civil court process. What does it mean? How can care help? And what are some of the services that we're talking about? First and foremost, care is a trauma-informed, person-centered process. So that means throughout the care experience, interventions and services are designed with that individual in mind, with that person's sense of recovery and autonomy. So there's no one size fits all. Some of the trauma-involved services that are offered includes really robust outreach and engagement. So that means multiple attempts to meet with someone, to begin to build autonomy and trust, to engage the person in potentially receiving services, really about meeting the person where they're at. I mentioned comprehensive wraparound support. Often that might come in the form of an FSP program or an ACT team. There can be supported housing and other supports that include care coordination and really this multidisciplinary package of services for the individual. Medications may be included as part of the CARE Act. They certainly are available to folks who might benefit from them, as are peer recovery supports. A super important relative aspect is that often peers can engage with folks more than licensed professionals can. And so others with lived experience is a vital part of the care process, as is volunteer supporters. And these are folks who the individual selects to help ensure that their voice and their choice is heard throughout the care process. I do want to mention psychiatric advanced directives, and these are opportunities where the individual who's involved can document their wishes or preferences when it comes to future treatment. And so it really is a chance to express what matters to them if they're not able to make a decision for themselves. And so we have lots of resources that you can look at on psychiatric advanced directives. Couple other things that I think is really important to stress here is that not only does care hold the respondent accountable within services, but it also holds the counties responsible to provide the services. So now we have two beings that really are working together to, again, ensure that there's a robust package of services for the individual. Again, could involve care management, FSP, housing, medication management, peer support. And then last, also equally important, is that care really is the least restrictive option that always should be considered when we're talking about treatment services for an individual. Care is certainly the least restrictive option, especially when we talk about the potential of conservatorship. Let's dive into it a little bit more as we go forward. Care eligibility criteria. I'm going to let my colleague Laura talk about that in more detail. We have the eligibility up here, and you can look at that in more detail, or there's lots of links that are included. What's really important is that you familiarize yourself with care eligibility, but need to know that you don't have to prove the eligibility. Your job is really to give the judge enough information that he or she can determine if the person meets or may meet care criteria. And so the idea of this is, and again, Laura's going to talk about it in more detail, is document what you know, what you observe, what you've witnessed, and what you've experienced when it comes to the eligibility. Enough of that. Let me move on to one more slide. When we do talk specifically about schizophrenia, spectrum, and other psychotic disorders, again, the CARE Act is designed for people who are living with schizophrenia or other psychotic disorders. And so there's a number of diagnoses that are included. You will see that on the side of your screen. Important to know that only schizophrenia spectrum disorders are covered under the CARE Act. Some of these might include schizophrenia, schizoaffective disorder, schizophreniform, also brief psychotic disorder. There are a number of conditions that do not meet eligibility criteria. One other note on this is that a person can have occurring substance abuse. And so certainly we could see somebody who has schizophrenia and substance use disorder. Substance use disorder alone is not an eligible condition. Again, we're going back to the schizophrenia spectrum and other psychotic disorders. I think I will turn this over to my colleague, Laura.
Thanks, Deborah. And let's just move into petitioning for care from a hospital or emergency department. So one unique thing about CARE is the fact that there's an array of eligible petitioners, including clinicians, first responders, family members, even the respondent themselves. So in terms of hospitals and emergency department staff as petitioners, CARE Act specifies specifically that the director of a hospital or their designee, where the respondent is hospitalized, can file a petition. And also any licensed behavioral health professional or their designee who is currently providing care for the respondent or in the last 30 days had been involved in the respondent's treatment. Those are also eligible petitioners. And again, both of these petitioners include a designee, like I just mentioned, meaning individuals that the organization who has identified by the director to complete the petition. So a designee of the director of a hospital could, for example, include a psychiatrist, a psychologist, a social worker, or any other designated treatment team member. So keep in mind that petitioners can partner with other petitioners to complete that petition. For example, a first responder who is also an eligible petitioner is completing the petition. Hospital staff could help complete that additional documentation, and we'll discuss that in just a moment. So let's go to the next slide. So moving to the actual petition forms and their purpose, which is, it's really not proving everything up front, like Deborah mentioned, but to really give the judge enough information to decide whether or not that case should move forward. So based on what's submitted, the judge may either dismiss the petition or ask the county BH agency to investigate further. So again, this means it doesn't need to be exhaustive what you're completing with the petition, but it should include, like Deborah mentioned, what you know, what you've observed, enough to reasonably believe that the person may meet care criteria. So there are two different ways reflected on the slide to file a petition, depending on who you are and what information you have. So we're going to touch on option 1 today, but we're really focusing on option 2, as those, petitioning from a hospital or emergency department will likely fall under that category of option 2 of the licensed behavioral health professional. Both options, these forms are asking for information about you as a petitioner and information about the respondent. And really the bulk of these forms focus on capturing information related to the individual's potential eligibility. So quickly with option 1, which is sort of the general petition process for most petitioners, you would use this path if you aren't a licensed behavioral health professional, but still eligible as a petitioner. In this case, you may be a first responder who's involved in referring someone to the emergency department. So option 1 would also be an option that family members consider when they're meeting with emergency department staff who may be discharging the patient back to the community and want to provide options to families about petitioning to CARE. So option 1 includes the CARE 100 form, and that asks the petitioner to explain their observations in their own words. Again, for today's purposes, this would be for non-clinicians interacting with an ED or a hospital, who in this case, again, could be first responders or family members. So with option 1, the petitioner needs to include one of the following things to support that petition. The CARE 101 form, and that is a declaration from a licensed behavioral health professional who's either examined the person in the last 60 days or attempted to examine the person multiple times. The family member or first responder may reach out to this individual to provide the additional clinical information included in the CARE 101. And if the individual doesn't have access to a licensed behavioral health professional to complete that CARE 101, other documentation can be provided. Specifically, this would be evidence that the person has at least 2 14-day holds or 2 5250s, one within the last 60 days. And evidence could include hospital discharge papers or a signed declaration from someone with direct knowledge of the hospitalizations, If the petitioner has knowledge, the declaration of the 250/250s can be included directly on the Care 100. Otherwise, that information can be attached to the petition. Okay, so now we're moving to option 2. Spent more time than I needed to on option 1, but option 2 is that more streamlined process for licensed behavioral health professionals who want to complete the petition themselves. As a licensed behavioral health professional, either working in the ED or hospital, you can use this path. So in this case, you'd fill out the Care 102 form. This combines both the petition and the declaration from the licensed BH professional into one document. So like the Care 100 and 101, it allows you to describe what you know in terms of the patient's history, their diagnosis, including current assessments, plus what you've observed and why you believe the person, again, may be eligible for care. Often, if the patient also has a recent history of a psych hospitalization, the ED or hospital staff may choose to include this with the Care 102 response to bolster that petition. All right, now let's go to that next slide. So again, most questions in the petition are essentially meant to help the judge decide if the person meets or may meet care eligibility. We're really trying to reinforce that you don't have to prove it definitively. It's just enough information for that judge to make a determination. I'll be speaking to one aspect specifically of eligibility, serious mental disorder, in just a moment. But looking at the full list on the left of the slide that Deborah just mentioned earlier about eligibility, there are some additional criteria you'll also be asked to document. So first and importantly, an eligible diagnosis, which Deborah kind of described the array of diagnoses that may be eligible. And remember, you don't have to have a definitive diagnosis. It could be provisional or even a diagnosis by history that you have learned when you've come to care for the individual. You also need to note that the person's at risk of harm or deterioration without support, and that they're likely to benefit from care as a less restrictive option. And this one is really important to note that the individual may still be eligible even if they're currently enrolled in outpatient treatment, but they're just not stabilized or engaged in that treatment program. So, in addition to these areas of eligibility that you're going to be asked to speak to in those petition forms, as a behavioral health professional, you can also provide additional clinical information, additional insights, any other details that you think may help the court determine eligibility. But let's just focus on one aspect of eligibility that you'll be asked to document in these petition forms. So we're going to focus on serious mental disorder. And there are 3 components of serious mental disorder that you'll be asked to speak to. So the first is noting that the mental disorder is severe in degree and persistent in duration. This is where you can speak specifically to the severity of the symptoms you're observing. So you see here examples on the slide of some of these symptoms, the speech, the behaviors that you may want to note, including how the illness may be impacting the individual's insight and judgment. And then with regards to mental disorder being persistent in duration, you want to note how long those symptoms have been observed. Any knowledge you have of the date of or approximate date of the initial diagnosis. The second area that supports that assertion of serious mental disorder that you'll need to document is any behavior that is interfering with the individual's activities of daily living, or commonly known as ADLs. Some key examples of how you might want to document these are noted on the slide here again, really related specifically to self-care and those day-to-day functional tasks. The third supporting assertion of serious mental disorder is that without treatment, without support, and without rehabilitation, that person will not be able to maintain stability or function independently. So you want to consider any history of housing instability, history of social relationships, maybe they're at risk of isolating, and they're functioning in the community generally. So it's also really important to note your objective observations. I believe Deborah also mentioned this as well, or others' documented observations, say from the clinical record, of these symptoms or behaviors that may be interfering with their safety, stability, and their overall functioning. So let's briefly talk about the petitioner's role after the petition is filed. So the original petitioner from the hospital emergency department will need to be present and can make a statement at the initial appearance. And you want to note that what we're hearing, a lot of the courts are allowing remote appearances. And also during that initial appearance, the court will replace the original petitioner, which would be you, with the county behavioral health agency, who from there on it will be considered the petitioner. And then after that point, the original petitioner wouldn't be required. You would not be required to attend future hearings. And in some counties, we are hearing that the court works to really efficiently replace that original petitioner with the county, knowing that the court appearance can pose a burden to hospital and emergency department staff. So that was a quick overview of the petitioning process, what you might need to include in the petition. I'm going to pass it now back to Deborah to talk about those LPS facility referrals to care. Deborah?
Yeah, thank you, Laura. Let's jump forward and actually put this into action. You've heard us so far talk about petitioning. I'm going to talk a little bit about petitioning versus referral. LPS facilities and hospitals have the ability to both refer or to petition, and I want to talk about the difference between the two. So first is the petition. That's when somebody, an eligible petitioner, actually files the petition with the court directly. And so in this situation, the petitioner is completing the forms, they're submitting it either electronically or in person to the court. And as Laura just mentioned, at the initial appearance, the county behavioral health agency will then take over, will assume the role of petitioner. Another option that's available to facilities, to hospitals and others is a referral. And in this situation, if your hospital is an LPS facility, and I'm going to talk about who is an LPS facility in a moment, then you can provide information to the county behavioral health agency saying to them, hey, will you please consider this individual as a potential care respondent? So in this situation, rather than filing directly, you're giving all of the information that's available to the county behavioral health agency, asking them to consider filing a petition regarding the individual. And so it's important to note here that regardless, a petition always needs to be filed in order for the care process to happen. And so that might occur with the county behavioral health agency when they receive this referral. In this case, they will consider eligibility, they will consider the documentation, and they will ultimately evaluate the individual and decide if perhaps they should move forward with a care petition. So a few things to think about is that there are processes that could be developed. We've heard from different county behavioral health agencies and from different LPS facilities that they've created workflow for efficiency when they make referrals. And a couple of benefits to referrals is that the individual can be recognized very quickly so that services can be designed really on a timely basis. In some cases, there may be improved outcomes because if the county is accepting and pursuing referrals in the form of petitions, then there's more likelihood of appropriate services being provided to that individual or being offered. And again, we're talking about streamlined processes that it could potentially expedite the process if your facility is working with county behavioral health to create and to file a care petition. So before we move forward, just again, quick note, petition is when you are actually filing the petition with the court directly versus referral is when you are asking your county behavioral health agency to consider filing that petition. Let's move forward and I can talk a little bit about referrals and specifically referrals from an LPS facility. Really important to note, the first thing is that there's some links at the bottom of the screen. The details are in Senate Bill 42 and the amendments, or the brief is located there. And so for more information, you can go on to care-act.org and find information, which I'm about to talk about. And so within the statute, there are some specifics about referrals, I should say, designated identified referrals. And sometimes we talk about those with a big R, or we talk about them as statutory referrals. And these are ones that are coming from those specific facilities. Within the statute is some very specifics about timing. Really, consideration of the referral should be done early in the discharge process, and giving some thought to when you might make the referral to County BH. The county behavioral health team, in return, has 14 business days to assess the individual after you make that referral. And it's in that time that they'll try to establish if the person meets or may meet the eligibility criteria. That is the threshold for the judge. Also important to note that if the person is on an involuntary hold, that nothing in this care process allows for the facility to extend the hold. So somebody cannot be kept there or held until a care agreement is in place. Treatment should pursue, as typically would happen for the individual. Also, a care referral doesn't preclude you from making an AOT referral as well. The idea is that you're really ensuring that there's some coordination of services and of practices. So again, if you think about your relationship with your county behavioral health agency and you consider whether for an individual filing a petition or making a referral is really the best path for you and for that individual. Let's go forward. I wanted to talk a little bit about who the eligible facilities are. Really important that, as I say, referrals are in the statute. It specifically talks about people who are in an involuntary hold. And so that includes facilities that are authorized under WIC Code 5150. And that's facilities for providing evaluation, crisis intervention. You can hold an individual for treatment and evaluation for up to 72 hours. It also includes designated mental health facilities. And so these are facilities that are licensed or certified as mental health facilities under WIC Code 5008. More importantly, this is really talking about licensed psych hospitals, licensed psych facilities, or certified crisis stabilization unit. And so if you're one of those, you do have the opportunity to make the statutory referral to the county behavioral health, who must accept it and again evaluate that person or evaluate the information within 14 business days to decide if a care petition may be filed. What does that referral look like? Well, there are some forms that have been included under the DHCS website. We have the form on the right side of your screen, and these forms are available to guide the process of what might be included in the referral. Certainly, hospitals or other facilities have the option of creating their own referral form. County BH might create their own referral form. What really matters is that it's comprehensive and it includes the minimum information that I'm going to talk about. So along with this, before we talk about it, it's important to note that the model of care coordination plan should accompany these details. These would allow the county to really have a full picture of what's going on with the individual that you're considering. So if you do use your own form, the minimum information is listed on the screen. I'm not going to go through all of it, but it certainly would be things you expect: the person's name, if they have Medi-Cal, the facility, the date of the receiving, the date of the referral, etc. It's going to be just core information and whatever's available. Really, the idea is that you're going to give anything that could help the county understand why you're making that referral, what's the person's potential eligibility, what's the person's diagnosis, what's the situation that's going on with the individual. And then also really important to note that according to statute, that you need to demonstrate that a licensed behavioral health professional was authorized to make that referral, meaning that the person who is making it has knowledge about the individual's case, has been involved in the individual's treatment during their involuntary hold, and really important that you believe the person is likely to meet care eligibility criteria. Again, don't have to be certain, give it your best work to demonstrate why care eligibility may be established. And so multiple links on the bottom if you would like to learn more. Back to you, Laura.
All right. Thanks, Deborah. Well, we're going to finish with just thinking about workflows from the hospital, from the ED. You know, when you are either referring an individual to care, as Deborah so nicely described, or petitioning, as I talked about earlier. So let's just briefly cover some workflow recommendations. You know, when might you and your team have these discussions and what these planning workflows might look like? So we have some recommendations based on what we've already been hearing from counties. Um, so thinking about when you might assess for care eligibility. Maybe it's when you're completing that initial assessment or that psych eval. This again could happen during the evaluation in the emergency department visit or during that admission process. And then you want to discuss with your team. So is the decision to refer or is the decision to petition for someone to care? And then and include the patient earlier than later in this decision, either referring or petitioning. And you know, when you're having that discussion with the patient, that's a great opportunity to educate them about the benefits of care, those services and supports that they may better, more easily access and be prioritized for them, and just generally educating them on that care process. And if you're in the ER, you know, think about working with your supervisor or, you know, your protocols in terms of the team members that you want to engage with to make that decision to refer or petition. And then from there, really just you want to think about the identified team member who's going to lead this process and work on the next steps. So this really means identifying who's actually completing the referral form, who's completing the petition. In some cases, it could certainly be a team effort. And we've also heard from hospitals that they're pulling content from the electronic health record, EHR, to help populate the referral content or populate the petition information on the 101 or 102. And if the patient's agreeable to the referral or the petition, having them sign releases of information sooner than later is a huge benefit to, you know, expediting the process and ensuring that there's good continuity of care. It allows you, of course, to be able to start speaking to those providers that you're hoping to engage the patient with while you're doing that discharge planning. And it really also promotes that voluntary nature of care. And again, the importance of partnering with the patient in the process. So coordinating with county behavioral health, again, sooner than later, is also key in supporting that timely response from the county, especially when they have that time frame, that 14-day time frame to respond. And again, specifically with the referral, which is that time-bound referral. So timing is critical. Ideally, again, the referral to care should be integrated into your discharge planning efforts, into that whole process. A lot of you've probably heard the saying, discharge planning starts on day one of admission. So you really want to think about, you know, day one, the timing of that referral, the timing of the petition, when you're actively engaging in your discharge planning efforts. Again, to support that good continuity of care, to make sure you're coordinating with the county and also with those potential services and supports for the patient that could include housing to really support a timely discharge as well. And again, the discussions of timing really need to happen with the team and with the county and of course with the patient. So I saw we just went to the ideas in action. Let's go there. And I will pose a general broad question to you, Deborah, you know, thinking about what we've discussed today. What are your takeaways? What do you see as, you know, something clinicians should consider when they're preparing to complete a referral or preparing for petitioning for someone to care?
Yeah, it's a great question. Great summary question. So what's important? What do you want to think about? We've said it a few times, familiarize yourself with the eligibility. It's not a test. You don't have to be perfect. Do the best that you can. Just think about, does the individual potentially have a qualifying diagnosis? How are you able to document that? How are you able to demonstrate maybe that some impaired functioning? Your job is to do enough to give the judge the opportunity to make a decision if the person meets or may meet criteria. I really appreciate Laura saying, talking to the individual, talking to the patient, really thinking about taking time and explaining the care process before you file a petition. Think about who else you should be talking with, other treating providers, perhaps family members, peers, other people who are involved in the individual's life. So really talking about care openly with people who are touched by it. I would encourage you to think about gathering documentation, whether it's a medical record, an evaluation, treatment notes, things that would support the petition, certainly history of hospitalizations. And then I talked about talking with others, but I really think collaboration is the key. Not only collaborating with the individual and with treatment providers and family, but collaborating with the county behavioral health organization, the behavioral health agency. Really, that's where you can talk about what's most effective. Should we be filing a petition? Should we go with a referral? What's going to get the individual connected to care in the community? So that's a lot, Laura, but those are the things that I've been thinking about as we move forward.
Thanks, Deborah. That sums it up nicely. And I'm going to hand the floor to Patricia to close us out.
Thank you. So the goal is that by the end of the session, you would have an increased ability to know what the petitioning process is and the role of a hospital emergency department staff in care, understand some of those LPS facility referral processes, and then use hospital and ED workflows to consider care and promote continuity. So we do have some additional resources. So a number of resources if you want to go learn more. We have a landing page, resources for petitioners. It has some additional information about completing petitions, can walk you through what to include in addition to eligibility, which Laura covered. It can walk you through some of those other sections of the forms. We also have a training and resource library that you can go to get more information, a county directory that will bring you to both behavioral health and court websites by county, including some contact information. And then there are a number of ways to reach out to our team if you're looking for specific trainings, if you want to get notifications about upcoming events, and there are specific forms where you can request feedback or reach out to us at our email address. We have a number of training sessions on trauma-informed care and specifically walk through how to incorporate a trauma-informed approach into care processes. So you go ahead and take a look at those. And we also have some additional trainings on psychiatric advance directives and their role in care. Like I mentioned, there are a number of available trainings and resources. If you want to become more familiar with care, there are some trainings and resources pinned to the top, which are a good place to start. I mentioned there are really no wrong doors. So if you're looking for information, but you're not even sure what it is, go ahead and reach out to us at info@careact.org, and we can help point you in the right direction or connect you to resources. Thanks, and let us know if you have any questions.